Good morning, everyone. I'm Karina Hill, and on behalf of the Florida Alcohol and Drug Abuse Association, we'd like to welcome you to today's webinar entitled Cannabis Use and Pregnancy with Dr. Kara Skelton. This webinar is being made available through a collaboration of the Florida Department of Children and Families Office of Substance Abuse and Mental Health and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and the host by using the chat panel rather than the Q&A panel. Again, please use the chat panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the chat panel to send any questions you may think of as you think of them, the presenter will address them as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options are posted in the chat panel too. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FADA website within 30 business days. To access the recording and PowerPoint, go to www.fada.org, Resource Center Training Library. FADA produces many webinars and workshops with the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FADA website. You will first need to register or sign in to your account to complete the evaluation. Information you provide FADA as part of registering remains confidential. Statements of credit will be posted within 30 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary, and attending the full webinar is also necessary to receive CE credits or to access your statement of credit. Do note that the evaluation will close at midnight on Tuesday, February the 16th. 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license number for reporting to CE Broker when you register with our site for the first time. Please note that WebEx monitors your arrival and departure and provides a report upon completion of the event. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar. We are not permitted to provide partial credit. And with that being said, I'd like to introduce our presenter today. Dr. Kara Skelton is an assistant professor in the Department of Health Sciences at Towson University. Prior to her current position, Dr. Skelton completed her postdoctoral training at the Johns Hopkins Bloomberg School of Public Health, where her research focus was maternal and child health promotion. Dr. Skelton earned her PhD in health education and promotion from the University of Alabama at Birmingham and holds a master's degree in community health education. Her primary research interests include examining cannabis use during critical maternal and child health periods, including the preconception, prenatal, and postpartum periods. She has published an array of peer-reviewed journals and articles, including papers presenting findings on cannabis use during these periods using nationally based surveillance data. Dr. Skelton is a current pediatric research NIH LRP awardee, during which she will examine the relation between changing cannabis policies, prenatal use, and child health outcomes. Dr. Skelton is also interested in assessing how social networks are associated with cannabis use, which is a future area of research. Throughout her career, Dr. Skelton has worked with an array of partners, including Johns Hopkins University, Maternal and Child Health Bureau, Academy Health, to turn research into action. And Dr. Skelton, if you're ready, I'll go ahead and turn the presentation over to you.
Hi, Karina. Wonderful. Thank you. And thank you to everyone for being here and attending this webinar today. So I always begin understanding and presenting by what is it that we are going to learn today. We have a set of learning objectives that by the end of this presentation, we will have covered, and hopefully you will be able to apply in practice. First, we will review the epidemiology of cannabis use during 3 critical maternal and child health periods, focusing on prevalence during these periods. We will be discussing the potential adverse health effects of cannabis use during each period, but also how they are intertwined. We will be discussing recommendations on how we can inform and counsel women given the current state of evidence and what remains unknown in this area. And we will be identifying potential prevention and risk reduction approaches that we can utilize in practice. So first, I just want to say that I always refer to cannabis, marijuana as cannabis instead of marijuana, and I'll explain why. Cannabis is the most commonly used drug in the US, but really most people think of it as marijuana. In fact, with legalization and specifically commercialization, we have so many more types of products that are available that cannabis includes all of those derivatives from the cannabis indica and sativa plants. And now when we say the term marijuana, because of contemporary cannabis use practices, most people are only referring to the smoked form of marijuana via a joint. So to be inclusive of all of the potential derivatives, I like to use the scientifically accurate and botanically accurate term cannabis. So that's what I'll be using throughout this presentation. When we think about cannabis use, it is the most commonly used illicit drug in the US. But really illicit is a funny word to use because for many states and territories within the United States, cannabis is legal for medicinal and/or recreational use. And there are many reasons why use has been increasing since the early 2000s. This includes increasing social acceptance, along with decreased risk perception associated with use. But something that is specifically applicable to today when we talk about pregnant women is that there's a decreased risk perception associated with use during pregnancy, and also an increase in these false claims of safety during this time period. Most people are under the false pretense that because cannabis has been legalized, that it is safe for use, which is not the case. We also find that voter support has grown abundantly since the early 2000s as well. And I don't think that there is any denying the positive economic or social justice benefits to perhaps decriminalization. But there are also public health consequences, including maternal and child health consequences that must be considered. But for most voters and policymakers, the economic and social justice benefits outweigh the public health argument. When we think about the cannabis plant, We hear a lot of different abbreviations, THC, CBD, CBN. What are these different abbreviations? So cannabis actually contains over 400 compounds. But in terms to what I'll be focusing on today, it's really three principal cannabinoids of interest. And so the first one is delta-9 tetrahydrocannabinol, which is what people are most familiar with. This is what's referred to as THC. This is the primary psychoactive ingredient in cannabis that's responsible for that high associated with use. THC is also what's responsible for the reward and addiction risk associated with chronic or heavy cannabis use. It also is responsible for withdrawal-like symptoms, especially for those heavy or daily users, or those users with cannabis use disorder. We also have seen an abundance of CBD products. CBD is an abbreviation for cannabidiol, which is mainly known for its medical use. It's non-psychoactive, so it's not responsible for the reward and addiction risk. And it's typically known for its ability to relieve nausea and vomiting, or its anti-inflammatory properties. What's interesting is that as we see the THC potency of products increase, the CBD levels often decrease. And so most people who think that they are using a cannabis edible for its medical properties actually have a very low content of CBD. We also have CBN, and this is very basically cannabinol. This specific CBN is something that results as degradation of THC and can be manufactured. So when THC is exposed to light and heat, it breaks down, and the product left behind is the CBN. So when we're talking about the research and I say CBD versus THC, I want everyone to understand the difference between these different cannabinoids. When we think about cannabis commercialization, we think about an array of new products that have only recently in the past decade or so become available. So in addition to marijuana or hash, we have concentrates, we have oils, edibles, we have topical creams, we have CBD only products. And so trying to differentiate between the different types of products availability and the adverse health effects associated with use is very challenging. And we know that the legalization of cannabis has led to these different forms. And therefore, cannabis as we know it has changed over time. When we think about these novel products, we have different potency levels of THC, so different dosage based on the different product types, different cannabinoids that are available and manufactured in these different products. In fact, THC concentrations have increased over threefold between just 1995 and 2014, and even more so in recent years. We know that these highly concentrated THC products like dabs or waxes are far more widely available in states that have legalized recreational cannabis and can be as high as 23.7% to 75.9% THC. So a much, much higher concentrated dose than what would be previously available in only marijuana. As there are no other substances that are packaged in this particular manner, I, as a maternal and child health researcher, am particularly concerned about accidental ingestion of some of these products and the adverse health effects on young children and infants, which we'll discuss more coming up. But we also know with these novel products and cannabis commercialization that there are also new modes of administration, such as ingestion, that really of these edibles that weren't available, let's say 15 or 20 years ago, or topical application of, let's say, a CBD cream. And we'll talk more about these specific products and what's actually in them. So when we talk about a CBD product, a product that is only supposed to contain cannabidiol, we know that this is not always the case. In fact, there's been no comprehensive research on how CBD products affect the developing fetus, pregnant mother, or a breastfed baby. We do know that there are some FDA-approved CBD medications to treat nausea and vomiting for specific types of chemotherapy, but there have not been any tests done in women who are pregnant or are currently breastfeeding. And so when people try to make the connection between a CBD medication that has undergone FDA approval for a specific use, they believe that using cannabis products is also safe for them during pregnancy to treat nausea and vomiting, which is not the same. But we also know that because these CBD products aren't regulated, that they're not always what they seem. They can have other chemicals within the product, and they can also have THC in them, even though the bottle says it's only CBD. The FDA does currently have several studies ongoing that aim to examine the effects of CBD during pregnancy. When we talk about cannabis, I always get asked about hemp seed products. So hemp seed is a different product itself than something that has THC or other principal cannabinoids of interest. So hemp seeds are found mainly in trace amounts, minuscule amounts of THC and CBD can be found in these hemp seed products. And the FDA conducted a recent evaluation and found no objection to pregnant or breastfeeding women using these types of products. So if someone comes up to me and says, what type of product from the cannabis plant can I use? The answer would be hemp seed products. That's the only answer that we can give. It's the only thing that has been evaluated objectively and found to contain only very, very small trace amounts that would pose no harm to pregnant or breastfeeding women, and that is directly from the Food and Drug Administration. When we look at cannabis compared to other drugs, we have very minimal evidence. And there are many reasons that we have minimal evidence for cannabis. We know that cannabis is federally classified as a Schedule I substance, a Schedule I drug. That means it has a high potential for abuse and currently no accepted medical use. So research, high quality research, rigorous, robust research and even research trying to elucidate a dose response relationship is very challenging. But we also know that some of our surveillance systems that are reliant on self-report are not capturing a holistic picture of cannabis use. Some of them are still only asking about marijuana use, which a lot of people, a lot of pregnant women, in fact, believe is only referring to the smoked form. So they're not reporting use because it's asking about marijuana and they're using an edible. And it's not capturing the different modes of administration. There are also, we could spend a whole webinar going over how to improve our existing surveillance systems to better capture use. So high quality research with pregnant women is difficult. Adding in the fact that cannabis is a Schedule I drug also challenges it. And I really like to focus on these 3 critical windows. As a researcher, in my research, I very commonly use what's called the developmental origins of health and disease hypothesis, which is really just an approach that emphasizes the role that prenatal and perinatal exposure to different environmental factors has in determining the development of diseases when we are adults. So most of my research around cannabis use has focused on the preconception, the prenatal, and the postpartum period, including those women who are breastfeeding or donating milk. So we are going to move to just examining the different prevalence during these time periods. So first I want to highlight just a national study that was conducted that looked at data from the National Survey on Drug Use and Health, which is a representative population-based survey from a non-institutionalized population. And so this study shows the difference between pregnancy status, so pregnant women and non-pregnant women, and their self-reported use. And then we also, sorry, I got distracted by the chat questions. So what this is showing us is that we know that non-pregnant women are using cannabis at a higher rate than pregnant women. And we see that use in the first trimester is significant, but then it seems to taper off, which is very nice. We know that use among younger women, those women ages 24 and younger, are more likely to use cannabis during pregnancy, which shows where we can focus on. And we'll talk more about the differences in these socio-demographic characteristics for cannabis users. This graph presents results of also NSDA data, but more recent NSDA data, and looks at pregnant and non-pregnant women. And so if we could go back to 2015, we'd see that really use has been increasing steadily since even before 2015. And I've been in the cannabis field for a while now, but when we look at pregnancy use in 2017 to 2018, in 2018, we thought, wow, there's a significant drop. This is really great. Maybe we're going to be seeing a downward trend. And unfortunately, that's not what we've seen. And I anticipate that we'll only see increased prevalence for the year 2020. So pregnancy, we saw an increase, and then it kind of dropped, and then it seems to be upticking again. However, for those non-pregnant women, past month use is steadily increasing and has been steadily increasing. And when we're thinking about prenatal use, it's really important to think about preconception use, because we know one of the strongest predictors of prenatal use is preconception use. So let's keep that in mind as we go to our next slide, which shows the daily use. So if we look at the daily or almost daily use among women by pregnancy status, we see that, again, it seems that from 2017 to 2018, we were excited and thought, wow, we're going to start to see a downward trend on use. However, it does seem to appear to have that upward trend again. Similar to our past month use, what we see is that for daily or almost daily cannabis use for non-pregnant women, that it is steadily increasing. This is something to be aware of as we focus and talk about the different sociodemographic factors that are associated with use. And when we think about postpartum cannabis use, we know that anywhere from 6 to about 7 or 8% at a national level report using cannabis during the postpartum period. I examined a study using data from the Pregnancy Risk Assessment Monitoring System and found that there were 6.45% of women who self-reported using marijuana or hash in the 2 to 6 months after birth. Another study has found that up to 18% of mothers reported using marijuana, and I say marijuana because that's what the study reports, while breastfeeding. And we know that for those women who have opted to abstain from cannabis use during pregnancy, that in the postpartum period, relapse is very high following birth. It's a transition in itself, the transition to parenthood for first-time mothers and parents. And so this particular time period of postpartum is a high period for relapse. Another factor that's associated with use is actually the policy, recreational cannabis legalization. And so I looked at a study. Most of my research is at a national level or examining the specific influences that policies or environmental level influences have on cannabis use during these critical time periods. So I looked at several studies with several states with recreational cannabis legalization and several states without. And I compared time use during these periods, adjusting for known confounding variables like tobacco use and even maternal age. What I found was that those women who resided in states where recreational cannabis was legal were 1.5 times more likely to use cannabis in the preconception period, over twice as likely to use cannabis during their most recent pregnancy, and 1.73 times more likely to use cannabis after their baby was born. And you can see here that the adjusted prevalence estimates are also higher for these women who reside in states with recreational cannabis. And we know in general that there are many issues with self-reported prevalence, fear of punitive action for reporting use, national surveillance studies that rely on retrospective recall. So we know there are many issues with current self-reported data. Biochemical estimates of prenatal use can reveal approximately twice the amount of prenatal cannabis users. And in California, there have been very high rates of use that have been found using these biochemical estimates, and sometimes as high as 22% in a sample with pregnant adolescents and 19% for pregnant young adults. We know that a very small percentage of women actually disclose use to their health professional. So we'll pick this back up in a little bit when we talk about how behavioral health professionals can be a partner and an advocate. But we also recognize the limitations with existing biochemical estimates. These include the sensitivity of some of these estimates based on the timing and the dosage and the different mode of administration. Hair, urine, and meconium is supposedly the best to be able to detect prenatal use, recent prenatal use, and hair grows about a centimeter every month, I think. But more importantly, a large limitation, at least for me, is the punitive consequences that face women when they do have a positive test. And so in populations where there is universal screening, in those states that have not yet legalized recreational cannabis, women are fearful about the consequences of this biochemical estimate, and therefore they're less likely to want to discuss it because of this fear of punitive action, which is what we want to stray away from entirely. This particular study was conducted by Dr. Youngwolf, who I've worked with before, and this is a really interesting study, and one of the first that aimed to examine the different modes of administration for cannabis by women during pregnancy, but also before, examining how these modes of administrations changed as women became pregnant. What was found was that the most common mode of administration was smoking, so that marijuana use. But also the use of greater than one mode was most common in the year before pregnancy, indicating that women lowered the amount of different types of products or different modes of administration that they were using, but that the frequency of use varied with the different modes of cannabis administration. For example, using edibles versus smoking, or using topical creams that contained CBD more commonly than smoking a joint during pregnancy. And so this study was really interesting, and one of the first to really examine the different types of products that are being used during these time periods. And this is a big research gap in this area, is what is the frequency, what is a dose-response relationship based on the type of product, the mode of administration, and adverse health outcomes, which we'll talk more about as we get into this area. And when we think about why women choose to use cannabis during pregnancy, one reason is that many women report they are self-medicating during pregnancy and use it to help relieve nausea or vomiting, or they report it being used as a sleep aid, or they are using it to help pregnancy-related pains and aches, or restless leg syndrome so that they can go to sleep. Interesting, though, that so many women report using cannabis to alleviate nausea and vomiting during pregnancy is that there's a syndrome called cannabinoid hyperemesis syndrome, which is where this condition leads to, for those daily or chronic users of cannabis, it leads to severe and repeated bouts of vomiting. So it can actually worsen a pregnant woman's early first trimester nausea and vomiting. So for those daily users who are continuing, it may actually progress into this cannabinoid hyperemesis syndrome, where often it is rare, but often they can end up with very severe extreme symptoms. Women also report these perceptions that cannabis is safe to use during pregnancy, and they rationalize this by comparing cannabis to other products for nausea, let's say Zofran, with recent reports regarding the safety of Zofran during pregnancy. And so when conducting qualitative research, they're really elaborating and rationalizing this fear around using prescription drugs during pregnancy, and the fact that cannabis has been legalized for recreational use, and even some providers will prescribe it during pregnancy, that it is okay to use. Women also report that a large reason for use is a lack of discussion from prenatal care providers. So these prenatal care providers, a lot just completely kind of skip over cannabis. They perceive, and the fact that these prenatal care providers are just kind of grazing over cannabis or not asking about it or not bringing it up because they're unsure what to say, that actually, women have reported, it gives a false sense of safety, that if cannabis were something to be concerned about, that certainly the providers would have brought it up. And we know that that's not the case. So when we look at specific reasons associated with use, these can vary during these different critical periods of interest. This was a study that I conducted utilizing data from the Pregnancy Risk Assessment Monitoring System for 2016 and 2017. I really want to highlight this table. And so this was a case report using data from women in New Hampshire. I looked at the variation in reasons reported for use by the self-reported periods that they stated they used cannabis. During the preconception period, the top cited reason was for stress or anxiety relief, and it was followed by for fun or to relax. So that true recreational use in the preconception period. However, during pregnancy, the top cited reason was to relieve nausea, and it was followed by stress and anxiety relief. In postpartum, a majority of the women reported using cannabis to relieve stress or anxiety. There's one common theme here, is that women report using cannabis to help relieve stress or anxiety. So taken together, in my mind, this indicates that women in the preconception, prenatal, and postpartum periods could benefit from alternative solutions to managing their stress or anxiety during these critical periods. This is another study from Dr. Coe and colleagues who also utilized PRANS data from 2017, but they did it on a larger scale. And so they had several states, and here are 8 states, and states with recreational cannabis legalization and states without recreational cannabis legalization. And but they only focused on the prenatal period and found almost identical results to my case study in New Hampshire, in which the top cited reason in pregnancy was to relieve stress or anxiety, followed by relieving nausea and vomiting. Again, it seems that those are our 2 top cited reasons consistently. So women are citing that they are stressed and they are taking cannabis, using cannabis as a way to relieve some of that stress or anxiety. And there's no doubt that pregnancy is absolutely a stressful time period. But 2, we see that they are using cannabis to alleviate nausea and vomiting, and so providing them with other safer alternatives for which there is safety data in pregnant women could also be beneficial in reducing the overall prevalence rate in this critical time period. When we think about individual characteristics that are associated with use during pregnancy, we know that there are an array of socio-demographic characteristics, as well as other risk factors that contribute perhaps to the same pregnancy outcomes that may otherwise be attributed to cannabis use. And so it's difficult to assess the effect that's specifically due to cannabis exposure, as opposed to these socio-demographic characteristics. But compared to women who do not use marijuana in pregnancy, women who choose to use cannabis in pregnancy are more likely to use other drugs during their pregnancy. They are younger, as we've discussed in some of the previous slides. They have had fewer pregnancies and are often first-time moms. They are also more likely to use cigarettes, to smoke cigarettes. Concurrent tobacco use is very high in prenatal cannabis users, and that's consistent across states with legalized recreational cannabis and without legalized recreational cannabis. They're also more likely to drink alcohol during pregnancy, but also have a myriad of other mental health conditions. We've talked about nausea and vomiting in pregnancy, and in general, they report having more stressors. Stressors that perhaps have continued from preconception into pregnancy, and they weren't able to find a safe, effective stress and anxiety mitigation strategy. And unfortunately, they're also more likely to have very little or disrupted, limited prenatal care compared to those women who do not use cannabis during pregnancy. And so when we're thinking about when we discuss these adverse health effects in just a bit, when we say that women are less likely to have disrupted prenatal care, it's hard to differentiate between the outcomes that are solely associated with cannabis use versus previous access and having a maternity medical home. And when we think about prenatal use, it's also imperative to think about other caregiver use. So men are actually more likely to use cannabis than women. And when we look at the qualitative data that's very rich, women report it's very hard to abstain from cannabis use when their partner is also using in the home, which for me indicates that it more is about a family unit as opposed to a single prenatal user. And that many women report relapsing because their partner was smoking while they were pregnant and it was too difficult to abstain, or in the postpartum period, their partner was using, and so they decided to pick it back up. Women who report partner cannabis use have been threefold more likely to report cannabis use during pregnancy. And when we think about specifically regulation of use and possession in early care and education centers, a concern, this is really a concern as we think about infants being part-time, children being in part-time or full-time care. So one of my colleagues conducted, Dr. Grossman conducted a study that examined the state level regulations in these different centers. And so I just want to, and found a majority of states do not regulate use or possession of marijuana in these types of early care and education centers. So Florida, I did some research, and Florida does prohibit the use of marijuana in centers and homes, but it only prohibits possession of marijuana in early care and education centers, not in homes. So what that means is someone could be running an in-home daycare and could possess cannabis containing products in the home, which in my mind automatically goes to accidental child ingestion and how we can, practice safe storage behaviors of cannabis. Looking more kind of at a socio-ecological level, there are an array of factors associated with cannabis use. At a society level, we know that access to treatment, that the normalization of use, and even still stigmatization of moms who are continuing to use pregnancy, even with those in the cannabis community, some women who continue to use cannabis during pregnancy feel like they shouldn't, but have a hard time quitting. And so there still is stigmatization there, even though in general, there's more widespread socializing norms here. At a community level, we know that access to contraception, healthcare, and housing play a role. Most, a significant factor associated with cannabis use is that most women who continue to use cannabis did not have a planned pregnancy. And so perhaps increasing access to preconception contraception and care could play a large role in reducing continuation into pregnancy. And relationships. So partner use, we've discussed, is a significant trigger for moms in pregnancy and often is their trigger for relapse. But those women who have experienced domestic violence in a relationship, have a family history of abuse, or have experienced some type of physical, emotional, or sexual trauma are more likely to turn to cannabis. Both preconception and during pregnancy. And we've gone over some of these individual level characteristics already. As I've mentioned briefly before, one of the largest indicators for use or predictors of use is past use. And so anywhere from 34 to 60% of women continue to use cannabis into pregnancy. A large percentage of them will try to quit and taper and abstain. So that is something positive. But of users, 18% have met criteria for cannabis abuse dependence or both. In some of my research, I found that there's a trend that 20% of women use during all 3 time periods. So from preconception, they continue use into pregnancy and postpartum. We also know that single women, those unmarried women, are more likely to use, younger age, lower education, lower income women, and those who have experienced these stressful life events or have a clinical diagnosis of depression or anxiety, those who report severe nausea and vomiting in pregnancy, partner use, and also sexual minority women. Non-heterosexual women are more likely to report use than heterosexual women. So that's going to bring us to our first poll. So compared to the national average of prenatal cannabis use, Florida's prevalence of cannabis use during pregnancy is less than the national average, about the same as the national average, or higher than the national average. What do you think? We're going to reveal the answer in just a moment. You won't have to wait too long. Oops. I just accidentally revealed it. So I think this is always an interesting question to look at. Compared to the national prevalence, how does the state perform? And so we'll probably give about maybe 30 more seconds, Karina, and then close the poll. And once the poll is closed, we should be able to see how everyone resulted. Okay, there we go. So a small percentage said less than the national average. Some people reported about the same as the national average. A large amount, the most said higher than the national average, and then there were several who did not respond. So if you said that Florida prevalence of prenatal cannabis use was higher than the national average, you are correct. This graph looks at self-reported marijuana use among pregnant women from 2002 to 2003, all the way to 2017 and 2018. So you kind of see a back and forth until 2014, 2015. And then you see this large upward tick. So in 2018, at the national level, the national prevalence of prenatal cannabis use was 4.7. Florida is at 14.6 for 2017 to 2018. So over 3 times, almost 4 times the national average, indicating it's a significant problem. So now we're going to discuss, I know that there were a lot of questions in the chat about.
We have about 7 About 6 questions when you're ready.
Yes, you
Um,
can you can go ahead, Karina.
okay. Can we get a link to the research or survey data where most people believe that the term marijuana only refers to smoked marijuana? This data would be important to prevention efforts for messaging.
Yes, absolutely, Amy. My email will be at the bottom of this presentation. If you'd email me, that would be wonderful. I'm also in the process and have grant funding to evaluate a self-reported instrument for validity and reliability, and I'm looking at the differences between using the verbiage marijuana versus cannabis as well. And I'd be happy to share those once those validity results and psychometric testing are available.
Is drug testing during pregnancy mandatory in all 50 states?
It is not universal in all 50 states, no. And this even varies for states with legalized recreational cannabis, urine toxicology versus meconium screening. It's all over the place. And most states, even states where recreational cannabis is legal, states are testing. There's basically health inequities at a testing level, and that certain insurers like Medicaid require prenatal testing, and so it's more identified and utilized in certain populations, which approaches from this whole different type of social justice, health equity aspect. But to answer your question very briefly, no, it is not a requirement in all 50 states for meconium or hair or urine, or even just universal self-report screening. And we'll talk more about what the recommendations are from leading organizations in terms of screening later on in the PowerPoint.
Okay, thank you. I had a client who used it for her scoliosis during pregnancy. What would be suggested to be used instead? Women are very limited to what they can take during pregnancy.
Yes, so I'm not an MD. I'm not going to answer that question, but you can be pregnant and receive a medical cannabis card. It depends on the specific state and the provider. The general guidance, especially for prenatal care providers, is to limit or try to find a safe alternative for which there is safety data for, and we do not have any data that shows that cannabis is safe for pregnant women, even medicinally. There is no evidence in this area. So most medical professionals will opt to use something for which there is safety data in pregnancy.
Thank you. Fatal alcohol syndrome is common in the USA. Does the use of cannabis cause birth defects? Are there statistics on this?
So we will talk about this later on. The short answer is where there's conflicting evidence on the use of cannabis and specifically birth defects. That's because we know that women who use cannabis are also likely to use alcohol or other illicit substances. And so previous studies have numerous limitations in their methods, including their statistical models where maybe there's uncontrolled confounding. But we'll talk more about this when we get to the adverse health effects section coming up.
Do you have time for a couple more?
Sure, maybe one more.
Okay. I work with moms of newborns and pregnant moms, and I have heard that their doctor knows about them using, and I have even heard that their doctor advised them that quitting would cause more harm than good due to withdrawals. Of course, I've been trained to warn moms of the side effects of smoking or using drugs while pregnant or around newborns, but when that contradicts what a medical professional has told them, what do you suggest we say to these moms?
So this is a very tricky question, Christy, and and is something that is very difficult to address. Women are, and we'll discuss this more, at an increased risk for withdrawal symptoms, especially those physical or emotional withdrawal symptoms. And that is true compared to men. Women experience these symptoms at a higher rate. But that specific advice goes against the American College of Obstetrics and Gynecology. We will discuss what ACOG's recommendation is, as well as some other leading bodies. So it's difficult because you want to keep the rapport with the medical provider, but that is against the guidance from their leading body. I see one more that says, isn't it true mothers can lose custody of their children if found positive? In some instances, that is the case. In other states, a CPS case has to be opened, a Child Protective Services case has to be opened if they have undergone biochemical estimate and found, let's say at the time of pregnancy, that there was a positive toxicology screen. Sometimes CPS will go in, and so long as there's no paraphernalia in the home, they'll pass. Other times it just depends on basically who's going into the home and what they're seeing. If they see that there's no cannabis paraphernalia or other drug paraphernalia, sometimes they'll close the case. If they see that, sometimes they'll open up a larger case.
And has COVID affected any of the data?
Yes, COVID has definitely impacted national surveillance systems, state surveillance systems, and to the extent which we are unsure. But yes, absolutely. So I'll pause, and then hopefully we'll be able to take more questions in a bit. So we're about to discuss some of these adverse health effects, and a couple of people have hinted this and asking, what do you say to women? So let's think about this case study in which we have a 29-year-old pregnant female who doesn't admit to using other drugs, but discloses to you that she has been smoking marijuana and using cannabis edibles almost daily, mainly for anxiety and sleep. How would you respond? Option 1, do not respond. There is too much unknown about cannabis use and pregnancy to counsel. 2, counsel the woman only on the legal consequences and potential CPS involvement if she continues to use cannabis. Counsel the woman that it's okay for her to continue using edibles, but you should absolutely stop smoking marijuana. 4, you could discuss what is known about cannabis use during pregnancy from a health perspective. What are the harms that are known from a maternal and a fetal or infant perspective? You could use motivational interviewing to make personalized goals to abstain from cannabis use, trying to meet the woman where she is, and provide evidence-based resources for the pregnant woman. So we will come back to this. Think about which combination, one or more, that you would use. And we'll come back for a reflection after we've discussed a few things. So Karina, this is our video if you want to get this started. I always say, don't take my word for it. Take the former Surgeon General's word. I'm going to mute. Great. Thank you, Karina. So I think that Jerome Adams does a phenomenal job very quickly, briefly discussing what we know about today's cannabis compared to previous forms, the difference between THC, and is always a nice little video to use. So before we get into the more specifics about these adverse health effects, I think it's important to upfront address the limitations of existing evidence. One of these is the way that cannabis has been assessed for the past many decades. It's mainly been included in a category with other illicit drugs. So what we know about marijuana use from the 1980s, marijuana was also included in a category with heroin or cocaine. So it's not relevant today. Sometimes we're unable to isolate the impact of cannabis because of it being included in this category with other drugs, because of the co-use of other substances during these specific periods. And often, even contemporary cannabis assessments fail to examine all of the types of forms and different modes of administrations, the different products, the different dosage of THC in different edibles, which is very challenging to interpret. And obviously the reliance on self-report, and especially retrospective recall bias, social desirability bias, are all at play when we're utilizing self-report. Looking at sample, some of these large cohort studies, one which we'll talk about in a bit, only had 84 women who reported only using marijuana. That's an incredibly small sample size and leads to power failure. And then even with biochemical estimates, there are issues with the timing of sample collection to exposure, when the last exposure to THC and the dosage versus when the sample was collected, that can influence the results. And it failed, some studies previously have failed to control for the use of other substances during pregnancy, such as alcohol or tobacco or opioids. And a lot of them do not capture today's cannabis user. So the contemporary use patterns and modes of administration of today's cannabis user, which is really important. Or also examine the role that mental health plays in using cannabis. The designs of some of these studies have been observational and retrospective due to some of the challenges I've mentioned earlier with collecting data on a Schedule I substance. When we think about the broad effects of cannabis exposure, it can produce an array of effects. The main active psychoactive chemical in cannabis is delta-9 tetrahydrocannabinol, that THC, which is what causes the user to feel high. But the consumption of THC specifically has really intense effects. It can impair endocrine system function. It can interfere with body temperature control and homeostasis. It can increase responses in cardiovascular systems. And these are just very generalized effects of cannabis, regardless of the age. It impacts your behavior. It can cause, THC specifically can cause our brain cell receptors to overreact, leading to some neurological effects, especially for those chronic or daily users. It can induce hallucinations, delusions, or psychosis, which we'll talk about more during these critical periods where there's undergoing a rapid transition of change and maturation from, being not pregnant to starting a family and thinking about that and moving into the transition to parenthood, which is a very stressful time. And the higher the dose of THC, the more likely that product is to produce anxiety or paranoia or psychosis. There have actually been a recent slew of studies examining cannabis use in adults and psychosis, which are super interesting, but not something I'm really going to dive into today. When we think about the different mechanisms of maternal and child health exposure, we have indirect, so in utero, breast milk, secondhand smoke, meaning that it's been somewhat metabolized before getting to the fetus or the infant. And then we have direct, accidental ingestion, where an infant or a young child is solely responsible for metabolizing cannabis and the components in that specific edible, let's say. But I'm also concerned about caregiver use and some of the issues resolving around these high THC concentrations. So inability to safely care for the infant, these improper storage of cannabis products. So when we talk about early care and education centers and possession in those type settings for a home-based center, that's concerning, as well as driving under the influence. So when we think about the effects of preconception use, we know that cannabis can impair endocrine system function, and this can lead to reproductive related changes, specifically looking at changes in sex drive and altered hormone levels. This is not a very well studied area in humans. There has been a lot of research done in animal models, and they are starting to look at human models. There's also evidence that cannabis can impact fertility, specifically for chronic cannabis exposure, because we know that the female reproductive system is influenced by the endocannabinoid system. And so it's very plausible that chronic exposure to cannabis can lead to these disruptions in menstrual cycles and depression of ovarian follicular maturation, or even the hormones that women need to ovulate. We know that the specific effects that, let's say, CBD has on estrogen signaling is even less studied than the overall effects of cannabis use on preconception health and reproductive health. But for example, for fertility specifically, these fertility related effects of cannabis may not stop when cannabis use is stopped. For some people, it can take up to 30 days for the THC metabolites to not be detectable, indicating a accumulation perhaps in the system. And THC has a long half-life in general. So when we think of some of the effects of prenatal cannabis use, we know that cannabinoids readily cross the placenta and enter the fetal bloodstream. And those plasma concentrations of THC can be anywhere from 10 to 30% of these female concentrations. It can produce high levels of carboxyhemoglobin when exposed to secondhand smoke. We know that other chemicals in THC and edibles and in marijuana can also pass through the placenta. And there's evidence that heavy exposure to prenatal cannabis, so those women who are using daily or perhaps have cannabis use disorder, meaning they need a high dose of THC and have essentially become addicted to cannabis, are more likely to experience and these withdrawal-like symptoms in newborns, like a high shrill cry, body shakes, etc. And there are many reviews that exist on this topic. Based on the review that you find, you could find one adverse health outcome is significant and another is insignificant, based on the inclusion criteria, based on the types of analysis that they did, based on when the included studies were performed. And we know that fetal growth and birth weight has been associated with maternal cannabis use during pregnancy. This is one of the areas where there is more substantial evidence compared to, let's say, someone asked about congenital abnormalities as a result of prenatal cannabis use. And so there's really weak evidence for any use. A woman used one once during pregnancy and an adverse lower birth weight or fetal growth restriction. But what there is evidence for is some type of dose response relationship for low birth weight, for gestational age, or for fetal growth restriction itself. And evidence from the American College of Obstetrics and Gynecology really does recommend that the timing of exposure may be important, although there's minimal evidence to back up what specific timing of exposure is most crucial. We do know that daily cannabis use during pregnancy has been associated with impaired fetal growth and increased placental vascular resistance, indicating concern for obviously continued growth and adequate nutrition. When we look at preterm birth as an adverse health effect of prenatal cannabis use, we know that preterm birth is defined as an infant having less than 37 weeks gestation. So some studies have not found any type of significant relationship due perhaps to uncontrolled confounding with tobacco or alcohol use at the same time period. There has been a systematic review by Connor. That was a nice systematic review with a meta-analysis, and it did find that there was an association between heavy cannabis use during pregnancy and preterm birth. But really there's mounting evidence in this area. And because of the mechanisms and the pharmacokinetics of cannabis, this is an area of specific concern. When we look at admission to the NICU, the Neonatal Intensive Care Unit, the National Academies of Science, Engineering, and Medicine say that there's little evidence on the association between maternal cannabis smoking and admission to the NICU, and they distinctly make this smoking of marijuana, right? So what's unknown is if this is due to the fact that you're more likely to have a baby who's born preterm, because we know those preterm babies are also at a higher risk for NICU admission. But there is systematic review level evidence with meta-analyses, as well as evidence coming out of Canada that has legalized as a nation, that there is an association independent of other types of drug use on admission into the neonatal intensive care unit. And we know in general, there is a lot of conflicting area for those infant health outcomes and these maternal outcomes. So looking at the quality or duration of labor, looking at the risk of miscarriage or stillbirth. There have been studies that have reported a risk of stillbirth or placental abruption or miscarriage. There's just not enough evidence to say conclusively that that is a real area of concern. We know too that infant outcomes like perinatal mortality or gestational length, birth defects, and these congenital abnormalities, really there's not enough evidence there either to say with certainty that this is a risk that we need to be letting everyone aware of. So those are kind of these short-term outcomes. When we look at data on the long-term effects of prenatal cannabis use, it really comes from these 4 studies: the ABCD study, the Ottawa Prenatal Prospective Study, the Maternal Health Practices and Child Development Study, and the Generation R study. So 3 of these studies actually were conducted in the 70s and have continued to, let's say, the early 2000s. And so some of the adverse effects reported in these studies are not reflective at all of today's contemporary cannabis modes of administration. The user who's using these different forms, or even the types of products and potency that's available. So when you look at these data on the long-term effects, my biggest concern is that most of it isn't really relevant to today's contemporary cannabis user. We'll discuss some of these long-term effects, though understanding that a lot of them were conducted many decades ago and continued for several decades when there were no edibles available or these other types of high potency THC products. So there is an interest in the long-term effects of in utero exposure, but really the most evidence consistently on long-term child health effects relates to these impaired neurodevelopmental outcomes. So revolving around visual acuity or verbal reasoning, impaired executive functioning, and also mental health, so depression, anxiety, and aggressive behaviors. This makes sense because as we'll talk about when we talk about postpartum exposure to THC, THC itself is highly lipophilic and it clings to fat. And so when we're thinking about an infant's brain that's growing and a fetal brain that's growing and developing, this is an area of concern. And we know that those that parental substance use and prenatal exposure to cannabis has been linked with future risk of substance use, but there's a lack of dose-response relationship and effects by specific type. So overall, there's insufficient evidence on these long-term health effects. What I would like to highlight is this study that is one small paper on the ABCD study. This study examined self-report exposure in pregnancy. So self-report, but it was actually an interesting study because it looked at three groups. A group that had no exposure during pregnancy, a group that had prenatal exposure, but only before maternal knowledge of pregnancy, and then a third group that had maternal knowledge of pregnancy and continued. So only for those women who had maternal knowledge of pregnancy and continued use was there a statistically significant association with lower birth weight or intracranial volume or these long-term psychosocial behaviors in children. So what this indicates is that the point of exposure may be key. On average, in this particular study, women reported finding out they were pregnant after 7 weeks. And what we do know is that this endocannabinoid type 1 receptor isn't expressed until about 5-6 weeks gestation. So perhaps this endocannabinoid type 1 receptor plays a key role in determining the adverse health effects associated with use, but certainly more information is needed in this area. So looking at the effects in postpartum, obviously there's a concern for mental health. If we know that cannabis use in general has these profound effects on behavior and the cardiovascular response and endocrine systems, when we're looking at a woman who is undergoing this rapid change of time. So when we think about that, I'm concerned for postpartum mental health at a time when they're already at risk for depression and anxiety, looking at the ability to adequately care for an infant, and also these infant health outcomes that are associated with being exposed to tainted breast milk that has THC or secondhand smoke exposure or accidental ingestion of cannabis. I want to highlight the study and then we're going to take a break in like 2 slides, if you'll bear with me for 2 slides. So this study was looking at cannabis concentration, cannabinoids concentration in breast milk, and what they found in this study was that THC can be detectable for up to 6 days after the last use. And not only that, but THC has a long half-life and is slow to accumulate or is slow to eliminate, which means it has this accumulation effect and builds up in the system, the infant system over time. So THC is highly lipophilic, meaning that it clings to the fat, and therefore THC is stored in lipid-filled tissues like the brain. And there have also been increasing evidence showing that THC may inhibit the production of prolactin. So we just discussed that it's detectable and it appears to have this compounding effect, but also alarmingly is that THC can be detected in infant feces for those who are breastfeeding, which means that there's some type of systematic absorption of cannabis. And so we will pause here and take our 5-minute break.
I'd like to welcome everyone back. Dr. Skelton, if you're ready, we'll go ahead and get started again.
Wonderful, Karina, thank you. Great, so when we think about cannabis exposure via breast milk, we know that infants are exposed during a rapid time of central nervous system development. Short-term effects include infant sedation, which can lead to poor infant feeding and thus poor infant weight gain in the first month of life. But overall, there's mixed evidence on the long-term effects on infant development from prenatal breast milk exposure. Often these moms are also using during pregnancy, and so there's a compounding effect there. We are unsure if it's because of breast milk or prenatal use. When we think about postpartum exposure, we're also interested in accidental child ingestion. A recent systematic review found that most child cannabis exposures are accidental and are highest among children aged 1 through 3, and most of the time the products that they ingest are edibles. But overall, we see these higher rates in legalized states, and we see an increase in medical consequences associated with these exposures because of the high THC levels, such as pediatric hospitalizations and perhaps even stays in the NICU. This is unsurprising to me since we know that the effects of THC exposure in children are more pronounced. And these are just a few of the symptoms that we should warn parents to be on the lookout for. We are also concerned about postpartum exposure, secondhand smoke to infants and young children, or even secondhand smoke to a recovering mom. So there's a little available evidence in this area, but we do know that secondhand smoke does contain THC and can produce the same physical effects as direct THC exposure. And chronic exposure can lead to executive functioning, impairments, IQ, those same type of neurodevelopmental consequences that we're concerned about during pregnancy. We have discussed the research gaps in terms of these dose-response relationships or effects by specific product types, and even overall household use, who is using in the home. But given all of the available evidence that we have, the American College of Obstetricians and Gynecologists says that women who are pregnant or contemplating pregnancy should be encouraged to discontinue marijuana use, and that women who report marijuana use should be counseled about the concerns regarding these potential adverse health consequences of continuing use during pregnancy. So again, ACOG recommends counseling women to discontinue and abstain from cannabis use, and also discuss with them these potential adverse health effects. Additionally, the American Academy of Pediatrics says that there is no safe amount of marijuana use in pregnancy or while breastfeeding that has been proven safe. We also see the same warning that was delivered from the former U.S. Surgeon General, in which, because of the health risks of marijuana use during pregnancy, we, encourage moms to abstain from cannabis use. I was a few slides away from my breaking point, but that's okay. We'll just continue on. So how do we inform and counsel women about this concern regarding cannabis use in these time periods, given the state of evidence? Well, we know that we should follow the guidance by these leading bodies, and that we counsel women who are intending to become pregnant, because preconception use is the largest predictor of prenatal cannabis use, as well as those moms who are currently pregnant or breastfeeding, to discontinue cannabis use. So we can use motivational interviewing to help women make life changes through this individualized approach and goal setting. But we also want to communicate the effects for both direct and indirect exposure. And we want to provide tailored resources for women that link them with non-punitive community supports. So as opposed to providing them with the CDC fact sheet, which we can absolutely do, it would be more helpful if we provide a tailored list of community-based resources that we can link them with. And we know that not all women are going to abstain from cannabis use, especially those that perhaps have young children in the home. And we want to make sure that we counsel on responsible cannabis use when there are children in the home, and ensure that families know what to do in the event of an accidental child ingestion, and discuss safe cannabis storage in the home and what that looks like. We also know that when we're discussing the effects that we want to provide scientific, evidence-based, and accurate information. As is my challenge today, the main challenge is not to overstate the evidence, but to state in a matter of fact and very clear, direct, simple way what we do know. We can restate laws in a simple manner, but not really have that be the focus. In terms of this punitive action, we want to focus on reiterating the potential consequences of continued use from a health perspective. We can have these tailored handouts and links to resources that are available. Magnets, some states are using magnets that families can have on their homes that have the Poison Control Center's number and signs of accidental child ingestion. So parents know exactly what to do in the event that their child accidentally ingests a cannabis containing product. And we know that we can use technology and social media to our advantage, especially when we're talking about health communication campaigns that we'll talk about in a bit. This is where women are reporting, getting a lot of their information. And so becoming aware of where they're receiving a lot of their cannabis related information and making a presence on those platforms can also be very helpful in communicating these adverse health effects. In fact, some states that have legalized recreational cannabis have designated social media teams that display public health messaging and different resources and facts and are communicating with women in these online platforms. So there's also some key discussion points that we can bring up when we are talking about cannabis use in pregnancy. So stating things like there is no evidence to show that marijuana use helps manage morning sickness. There's no evidence to show that. Talking about marijuana use directly affects the brain. We don't have to go into the specifics that THC is a highly lipophilic substance and will accumulate in the brain, but talk to them about the developing brain in a fetus and an infant and a child are especially susceptible to these adverse effects. Talking about the different concentrations of THC in ingestible products, beverages or concentrates and edibles have a higher amount of THC and come with different risks than smoking. Not a lesser risk, but a different risk. And talking about what the concern around this neurodevelopmental outcomes for prenatal exposure as well as continued exposure, perhaps via breast milk or secondhand smoke as an infant. There are also some key discussion points that we can use to guide the conversations around the postpartum period. So talking about the health effects of use on maternal health, on breastfeeding, on secondhand smoke. We know that it's recommended that infants reside in the same bedroom as the parents for the first year of life per the American Academy of Pediatrics. So talking to them about not smoking in their bedroom, not smoking in the house with the infant can be a good starting point. Talking about the safe storage of cannabis in the home, having them in a locked, secure place out of the reach of children, and never leaving cannabis products or cannabis paraphernalia around the home or within the reach of a young child. Children do not understand that a green leaf that looks like a plant is a harmful substance. And then talking about the safe use, especially for those women who, verbally say that they are not going to try to discontinue. Talk to them about responsible use in the home. So let's reflect back on our case study. We have this pregnant woman who doesn't report using other drugs, but reports using cannabis and edibles. How do we respond? Well, we want to discuss what is known about cannabis use during pregnancy from a health perspective. What are the potential harms for the mother and for the fetus and the infant? We want to integrate motivational interviewing into our session and make personalized goals to abstain from and discontinue cannabis. Trying to meet the woman where she is. It may not be possible to completely abstain in 2 days, but setting a goal to get there. And then providing evidence-based tailored resources for these women. So what are some potential prevention and risk reduction approaches that we can use in practice? And so we briefly discussed this earlier when we talked about that women are at a higher risk for having these physical withdrawal symptoms as compared to men. So it's important to understand this when we talk about encouraging women and helping them through this cessation process and thinking about the treatment process. These mood symptoms or even gastrointestinal symptoms like nausea and vomiting. So when we think about a woman who is trying to quit during pregnancy, they are more likely a daily user is more likely to have nausea and vomiting on top of perhaps the already experience of nausea and vomiting that occurs in the first trimester. Some effective practices in preventing substance use that have been identified are screening, brief intervention, referral to treatment, home visiting programs, contingency management programs, integrated clinics. And so we're going to go over these. One very effective practice that's been utilized in other illicit substances, especially during pregnancy, is the screening, brief intervention, and referral to treatment, SBIRT, which is supported by the American College of Obstetrics and Gynecology and many other professional organizations. And really, one of the ideas is that sometimes just asking about use can prompt change, but two, using validated questionnaires to help identify those women who may misuse cannabis or have cannabis use disorder, and trying to briefly counsel, see if they are ready to accept treatment, and if they are wanting treatment, to refer them to from the medical provider. In cannabis users only, SBIRT research is limited because it's so novel and because so few women use only cannabis. But we know from other studies, from other practices, and from other substances like alcohol or opioids, that SBIRT can be a very effective prevention strategy, especially in early pregnancy, in the first trimester. When we talk about the importance of asking and discussing cannabis use, like utilizing the screening, brief intervention, and referral to treatment, it's important to know that this is something that women are wanting. They want their prenatal care providers to disclose, to discuss and feel comfortable disclosing use. In a recent study by Holland, they recorded prenatal care providers' interviews and found that 48% of prenatal care providers did not respond to women when they discussed prenatal cannabis use. The woman disclosed that they were using cannabis and the provider did not respond. And for those that did respond, a large percentage only discussed the punitive consequences of use, like the potential for CPS involvement at the time of delivery, if it was detected via meconium, right? And they didn't discuss most of the time the information on health-related risks or outcomes. And because of this, because 48% of providers didn't respond to the disclosure, many women, a majority of women, are dissatisfied with the health communications received from their providers about perinatal cannabis use. And again, they perceive this lack of communication or counseling about cannabis use during these perinatal periods, that it's an indication of safety, which it is not. But often care providers are unsure what to do and how to discuss. But what's most important is that we do discuss what we know. And we can say several things that we know. And at the end of this presentation, I'll also be linking with specific resources that elaborate. Here is a beautifully designed document that is specific for Colorado healthcare providers. They talk about how to discuss and bring up the topic of perinatal cannabis use with women. They lay it out. They integrate the discussion into well woman and teen visits, so those preconception visits, but also talk about some of the specific laws. Developing a handout like this for providers gives them a starting point to go from, as opposed to providing no guidance. So something like this could be developed and tailored specific to Florida. We also know that from other substances, integrated clinics are a wonderful and very effective practice to utilize. Integrated clinics have been around since the early 1970s, but really the premise remains the same. It's this co-located healthcare and substance misuse prevention providers all in the same place that serve pregnant and parenting women. And so we can think of it as this one-stop shop, right? And they typically offer a combination of prenatal care, general care, counseling for mental health and substance use disorders, as well as other community-based support. Sometimes these integrated clinics can serve as the maternity medical home, whereas we've discussed previously that those women who are more likely to use marijuana and cannabis are also more likely to have disruptions in their prenatal care. Integrated clinics can reduce that disruption to the prenatal care. And specifically relating to women who use cannabis, integrated clinics have been shown to improve engagement in prenatal care, as well as treatment for cannabis use, misuse, and cannabis use disorder. And so we know that there's also birth and infant and child outcomes that are associated with utilization of integrated clinics. Another effective strategy is health communication programs and targeted messaging that there's already been a question about. So we know that having a targeted, tailored message will reach more people and will be more effective than a broad, not tailored to a language or sociocultural norms. And so realizing that younger women, first-time mothers, are more likely to use cannabis during pregnancy, that's a segment, that's an audience that we can tailor our messaging to. And we want to use clear, direct messaging, like there is no safe amount of cannabis use while pregnant or breastfeeding. So really trying to get at the denormalization of engaging in these risky behaviors during pregnancy. I do have a video here, but we're not gonna view the video for sake of time. But this is a video that is from the Substance Abuse Administration and discusses, it's a health communication campaign that's tailored on marijuana use during pregnancy. We can link that video for those who want to view it. We also know that integrating home visiting programs into partnership for preventing cannabis use can be beneficial, and home visiting programs are especially beneficial and important in the postpartum period, where the risk for relapse is very high for women. We know that home visiting programs can promote increases in positive parenting practices and linkages to those supports and referrals, so that if we do see a woman has relapsed, we can quickly get her the help and treatment that's needed. Another effective strategy is our contingency management programs. And these are typically implemented in a clinical setting and really relies on this operant conditioning, and that we are rewarding individuals based on a specific level of change. In the case of cannabis during pregnancy, it would be abstinence. So looking at contingency management programs, they have been effective in reducing the prevalence or even in successful abstinence from tobacco, alcohol, and illicit drugs. A recent study that focused on cannabis use specifically found that a contingency management program was successful in a set amount of time for these young adults. So not necessarily for long term, but perhaps for a pregnant mom who's interested in abstaining for the next several months, this could be an effective strategy to utilize. And we also know that we can be advocates for policies that protect, using those best practices from alcohol and tobacco control to prevent initial uptake of use as well as continued use. And we can rethink ways that safe disclosure of cannabis use can occur, because often, as several people have mentioned in some of the questions that have been asked, cannabis use is directly tied to punitive consequences. And we really want to try to get away from that, especially as states are legalizing recreational cannabis and voter and legislative support is increasing and growing. We want to advocate for holistic health and well-being that involves getting women the treatment and help that they need and linking them with resources that are beneficial in a non-punitive way. Of course, we want to prohibit marketing of these products to children and youth, although unfortunately that's not always the case. And one of the additional things that we can do just to kind of see how prevalence is faring in the future is to look at existing surveillance systems and see, are they capturing a holistic view of prenatal cannabis use or cannabis use in the perinatal period? Do they look at multiple forms of cannabis? Looking at and utilizing existing state governmental programs like home visiting programs and WIC to see how we can integrate surveillance and also these effective practices. Looking at milk banks, healthcare providers, and other caregivers as part of the solution. And we also know that there is a large need for enhanced cannabis education and training, not only for healthcare professionals, but for government program staff, policymakers, and even in the cannabis field, talking about, there's a really interesting study in which that happened in Colorado, and a team of researchers went in, acted like they were pregnant, and said and asked the cannabis dispensary staff, should they use cannabis? And less than a third said you need to check with your medical provider. Most of the cannabis dispensary staff actually said that it was okay for them to use. So really, we know that there's enhanced cannabis education and training that will especially be relevant as more and more researchers are studying this area and trying to address the vast research gaps. So here are some specific resources for behavioral health professionals. One is the health effects of cannabis and cannabinoids. That's a large report from the National Academies of Science, Engineering, and Medicine. I would direct you to chapter 10, which focuses on prenatal, perinatal, and neonatal exposure Their highlights are here, and this is where you're able to get this free report. Two, this is a wonderful guide from the Substance Abuse and Women's Health Services Administration and Mental Health Services Administration that is an evidence-based resource guide that practitioners can use, and it focuses on preventing and helping women abstain from cannabis use. It is a free download guide that's available. They highlight, SAMHSA highlights in this specific evidence-based document, this getting to outcomes model. So if you are interested in trying to instill these prevention programs for marijuana use and cannabis use in women, this is one of the ways that they focus on trying to get to the right outcomes. Here are a series of cannabis info cards. These are free cannabis info cards. They are clear, they are direct, they address some of the questions that women have, like smoking, eating, vaping. No matter how marijuana is used during pregnancy, there's a risk for baby. Most often, pregnant women believe that smoking marijuana is harmful, but that eating or vaping is less harmful. But in fact, there are different risks that are associated with these different modes of administration and products. There is the CDC fact sheet. This is a very generic fact sheet. Something is better than nothing. So having, the ability to link women with what is it that we know, something that you can go back and reflect on as well. NIDA has lots of, NIH, there's a lot of information out there. CDC, SAMHSA, Mother to Baby has a lot of great documents as well. And so does March of Dimes. So looking at the key takeaways from this presentation, there is no safe level of cannabis use during preconception, pregnancy, or postpartum. There is increasing evidence that's very compelling on the adverse health effects of cannabis use, particularly during the preconception, prenatal, and postpartum periods, both for maternal health and for fetal or infant child health outcomes. But we know that evidence-based communication is necessary. It is imperative that we communicate with women what is currently known, and as it adapts or changes, getting up-to-date real-time information. We want to take an individualized, tailored approach to counseling, treatment, and health messaging. And we know that there are existing potential prevention programs and risk reduction approaches that exist for women using cannabis in these time periods. So here's a brief, just check in on our learning objectives, and thank you.
Dr. Skelton, thank you so much for presenting today. You shared a lot of information, and we got a lot of great feedback from everything that you shared. We do apologize. There was a lot of information that we had to share today, so we couldn't get to everyone's questions, but we do have her email posted here. If you'd like to take a screenshot of it and email her your questions. When I conclude today's webinar, your browser will take you to an evaluation on FADA's website. If you want to receive CE credits or a statement of credit, please complete the evaluation. You will be prompted to register or to sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. After you register or sign in, you will be directed onward to the evaluation. You may consider using the same email address when you register for webinars through our WebEx link, and the same email that you use to set up your profile in FADA's system. This helps us connect your attendance and your profile. You will also get a second opportunity to complete the evaluation through a follow-up email later today, usually within about 15 minutes. The sender will be Messenger at WebEx. The evaluation will close at midnight on Tuesday, February the 16th. We do not email statements of credit. Instead, after we verify your attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. And again, it does take up to about 30 days. The archived material regarding with today's recording and presentation will be available on our website at the Resource Center Training Library. And we want to thank you for participating in today's webinar. We'd also like to recognize and thank especially the Florida Department of Children and Families Office of Substance Abuse and Mental Health for funding today's education. Have a great rest of your day and please hold for the evaluation. Thank you.